What's special about my doctor is that I feel like we have a partnership.
I didn't go to a GYN early on after my injury.
We work together. You know, I educate him more about my spinal cord injury, and then he's able to educate me more about women's health.
Maybe somewhere in the back of your mind, you're thinking you're not going to, have a period. You're not going to have sex. You're not going to have children.
It was stressed about females that you can live a normal life.
Research has shown us, and many women themselves have told us, having a spinal cord injury does not change the fact that they are still women, with all the same gynecological and reproductive issues all women have. Dealing with these issues just becomes different, and we as medical professionals have a commitment to help them maintain a high quality of life. In this program, we'll explore information to help women take responsibility for their gynecological health, including the importance of regular exams, such as pelvic exams, mammograms, and breast self-exam. We'll show ways for women to gain access to excellent care, and we'll discuss alternatives to the traditional positions for a pelvic exam and mammogram. We'll also explore menstrual management issues and pass along some coping strategies many women have worked out for themselves. We'll begin with investigating the importance of regular gynecologic exams. Current national studies on healthcare issues in women with disabilities have brought new information to the forefront of medical attention. Findings show that chronic health conditions occur in women with physical disabilities at an earlier age than able-bodied women. Also, some women lack an understanding about their reproductive health, and those with disabilities are substantially less likely to have regular annual pelvic exams. These findings stress the importance of teaching women with spinal cord injury to establish a relationship with a GYN healthcare provider. Dr. Amy Jackson.
It is truly critical that women with spinal cord injury establish a routine of getting regular gynecologic health care, just like any woman. We as healthcare professionals must help make it more accessible. Some physicians do not understand the effects of a disability on the reproductive health of women, and some primary care physicians don't see women with spinal cord injury at all, either because of a lack of knowledge or a lack of physical accommodations in their clinics and offices. Some physicians regard them as asexual and do not acknowledge their need for reproductive health care.
There is much healthcare professionals and women with spinal cord injury themselves can do to remedy this situation. The first, and probably the most important, is education. Women must take charge of their health care and become advocates for seeking and demanding better access to it. All women with spinal cord injury, just like all women everywhere, should undergo a complete gynecologic exam once a year. Health organizations recommend a pap smear, hemoccult test, and breast exam. A thorough bimanual exam should also be performed, in which a physician palpates the size of the uterus and ovaries. This is very important because over 15,000 women in this country will get cervical cancer every year, and close to 5,000 will be fatal cases. And to further emphasize the importance of yearly exams, there is a very long non-symptomatic period for cervical cancer in which early detection and curative treatment is possible. The pelvic exam can also detect sexually transmitted diseases, especially important because women with spinal cord injury who lack sensation may not be able to sense the discomfort often associated with them.
I mean, it's like you go into the tiny little room, and then there's the table, and it's up here, and then, the nurse or the doctor's assistant will walk in and say, okay, can you hop up here? You need some help? And, like she's maybe half the size of me or something. It's like, well, have you got somebody else to help?
It's like, so you got to have one person over here holding it, one over here. It's like, I don't want to be here in the first, but then I got this whole team of people in here while I'm getting my exam. I just hate that.
Certainly the whole process of getting on the table and using the stirrups and dealing with the nurses and doctors who didn't understand the disability, it was all just so frustrating. I didn't want to go back.
Knowledgeable consumers and healthcare professionals are the key to facilitating the exam for women with spinal cord injury. The best accommodation is to have a specially designed exam table. These tables can be lowered to wheelchair height, making it easy for women with lower levels of injury to transfer from chair to table.
Do you need any help with that?
After the two surfaces reach the same height, a sliding board can serve as a bridge between them. Be sure you check with a woman first before using a sliding board, though, because they can cause skin breakdown or exacerbate pressure ulcers. Once on the table, there is a special padding, such as sheepskin, to prevent pressure on skin. If an adjustable table is unavailable, there are many transfer techniques that can make moving onto a traditional table easier. For all transfers, a safety belt should be snugly secured around the woman's waist for the assistant to use if the woman should begin falling.
What you're going to do is just sort of twist me around up on the table.
The pivot transfer can be used if the woman has an incomplete or very low-level injury and is able to balance safely. An assistant can help her to a standing position and then pivot to place her on the table.
You ready?
I'm ready.
Well, that was pretty good.
Also, many women may prefer to dress and undress while on the table, and many will need assistance. It helps to speak with a woman about this before transferring. Another lift uses two people, one lifting the woman's upper body under the armpits with her arms folded across her chest, and the other lifting the woman's thighs and calves. The stronger person should always lift the upper half of the woman's body. Another useful variation is to stand behind the woman and grasp the safety belt around her waist. The woman is less likely to slip from your hands than when grasping her upper body. While lifting, the second assistant supports the woman's thighs and calves. This method is best used when the woman cannot fold her arms together. If the woman has a high level of injury or is unable to help with the lift for any reason, and if there are no available lifters, one creative solution may be to perform the exam while the woman is reclined in her own wheelchair. If her wheelchair doesn't recline, it's possible to rent a reclining chair for this purpose. Her legs can then be held up in place by one or two assistants. With any lift, it's important to keep a few tips in mind. As with all transfers and accommodations, the woman is the best source of information on her abilities to assist, the nuances of her wheelchair, and what transfers have worked for her in the past. She understands how to prepare her equipment and help those unfamiliar by explaining how her chair and supportive devices work. She knows how to remove armrests and footrests and other braces or devices to facilitate the transfer. She should also be in charge of moving her urinary equipment, making sure tubing is unstrapped and guided in the lift to prevent pulling and kinking. Assistants should always use proper lifting techniques to ensure there is no injury to themselves during the lift. Keep back straight and knees bent deeply. Never twist your body as you lift, and do not overestimate your own strength.
Okay, I want you to bend your arms. I want you to press down with your...
It's also wise to test the lift first, lifting only just above the wheelchair to make sure all involved are comfortable and able to perform the full lift. Also, the examples in this program are intended as an orientation. If your staff is unfamiliar with lifting techniques, consult a physical therapist for professional staff training. In addition to alternative transfer methods, there are a number of positioning issues that can help you perform the exam successfully and prevent the woman from experiencing pain and discomfort. One is for the woman who can balance on her side with knees bent and her top leg bent close to her chest. An assistant can hold her knees in place if necessary. Because the woman is on her side, the physician must take care to angle the speculum towards the small of the woman's back and not straight up towards her head. She will need to roll onto her back for the palpation. The diamond-shaped position involves holding the woman's feet together so that her legs make a diamond shape. You may use a pillow under her back or thighs to make her more comfortable. The speculum is inserted with the handle up. This is best used for women with flaccid paralysis. The V-shaped position can also be more comfortable than the traditional stirrup position, but it will involve at least one and possibly two assistants holding the woman's legs. Each assistant should support one straightened leg at the knee and ankle. The woman may be more comfortable with a pillow under the small of her back or tailbone, or with her legs slightly elevated. This position is particularly appropriate for women with pressure sores or those with contractures of the hips and legs, because the legs can be held at a safe and comfortable position without adding pressure to sensitive areas. It is also best if the woman is in bed while the pelvic exam is performed. If the stirrups position is used, the woman will need help to support her legs in the stirrups and may need additional padding on the table under her back and hips to prevent unnecessary pressure. Remember to use padding on the table and stirrups. OB stirrups support the legs for women with paralysis, since foot stirrups are very difficult for them to use. Knowledge of different positions and transfer methods for performing the pelvic exam will help medical professionals accommodate women with spinal cord injury. And as with transfers, women themselves are often the best source of information on how they can be positioned for an exam, taking into account their unique situation. Discussing how to facilitate the exam with a woman prior to beginning is highly recommended. In addition to these accommodations, there are a few other special concerns to be aware of.
Lisa, I noticed that you've got contractures in your knees.
Yes, ma'am.
Contractures are a permanent fixation of muscles at the joint, which can present many challenges to positioning. The same is true for heterotopic ossification and pelvic fractures, two other conditions that can affect the exam. Heterotopic ossification is the development of bone in abnormal areas. It may occur anywhere in the body, but most frequently is found around the joints or long bones and in the hips. Pelvic or femur fractures can occur in women with spinal cord injury and can lead to bony deformities. It's important to be aware of any contractures, joint limitations, or structural abnormalities before beginning, and be open to options in transferring and positioning to get an accurate exam. Discuss these issues with the woman to determine the most comfortable position for her.
Does that help, though, support your back a little bit?
Yes, it does. Okay.
Also, plan ahead if a woman has scoliosis, which is a pronounced S-shaped curve of the spine, or kyphosis, which is an exaggerated backward curvature of the spine. This can be especially problematic in women with spinal cord injury because it can cause many points of pressure on the skin. Use adequate padding on the exam table and take the nature of her bone changes into consideration when positioning. Prevention of pressure ulcers is also a very significant factor to prepare for. Many women are susceptible to skin breakdown, and unnecessary pressure can cause problems, even if applied for a very short period of time. It's important to use ample padding on any part of the exam table that may cause a pressure problem. Pay special attention to the area around the woman's sacrum, buttocks, and spinal area. Be careful of the areas where her legs and heels are held by the stirrups. If a woman already has pressure ulcers, use alternative positioning that will keep any weight from being exerted on these areas.
Okay, wait, I'm having, oh, wait a minute. Okay.
You having pain?
No, a little pain and spasm.
Okay, what can I do to help?
If you can just kind of hold
Pain
on.
can also be an issue. It can be localized in the back especially, and anywhere at or above the woman's level of injury. Be sensitive to how she is feeling as you position. Proceed slowly and adjust transfers, positioning, and padding as necessary. Knowing special accommodations for positioning and being aware of special concerns particular to a woman with spinal cord injury will greatly assist in performing an accurate and comfortable pelvic exam. There are a few other issues to consider. Again, we'll hear from Dr. Amy Jackson.
There are special bowel and bladder concerns that may be a factor in doing the pelvic exam. The pressure from the speculum, bimanual, or rectal exam may trigger a reflex that may stimulate the bowel, causing a bowel movement during the exam. Also, a woman's bladder management could include an indwelling catheter, with attached tubing and a drainage bag, usually held to the woman's leg with a strap. The indwelling catheter need not be removed during the exam unless it is not draining adequately and another catheter is available for insertion. Some women use what is called intermittent catheterization. This involves emptying the bladder by inserting a catheter at regular intervals during the day. Tactile stimulation or pressure on the bladder from the speculum can cause bladder reflexes or the bladder sphincter to open. If a woman uses this type of bladder management, it's best to have her cath herself just before the exam. These women will usually have their own catheters with them, but you should have catheterization supplies and assistance available if needed.
Another special concern to be aware of when working with these women is autonomic dysreflexia, also called hyperreflexia. It describes a set of reactions people with spinal cord injury can have to stimuli. This can become a life-threatening emergency in individuals with spinal cord injury at level T6 or above. Common signs and symptoms may include elevated blood pressure, a pounding headache, bradycardia, nasal congestion, bronchospasm, seizures, chills without fever, sweating above the level of injury, skin flushing above the level of injury, and goosebumps above the level of injury. A few precautions will prepare you for dealing with this emergency. Again, Dr. Amy Jackson.
Since autonomic dysreflexia is triggered by various noxious stimuli, you can be prepared by investigating what is likely to cause an episode in your particular patient. The most common cause during a pelvic exam is insertion and manipulation of the speculum. Other causes include reactions to a cold hard exam table or stirrups, pressure during the bimanual or rectal exam, and tactile contact with hypersensitive areas such as swabbing of the cervix. Some other common causes that could occur but wouldn't be related to the exam are urinary blockage due to a blocked catheter, bowel impaction, pressure sores, or extreme temperature change. Before beginning an exam, you should assess and identify potential problems in each patient. For example, if a woman has had episodes of AD related to her bowel or bladder program, she may very well experience an AD episode during the pelvic exam.
My head is hurting really bad.
Are you getting dysreflexive?
Yes.
In almost all cases, if a woman begins experiencing symptoms of autonomic dysreflexia, they will usually disappear if the speculum is removed.
Is that helping? Yeah. Feeling better?
You can then try inserting a smaller speculum or check for other stimuli that could be causing the AD, such as a kinked catheter or full bladder or bowel impaction. If AD symptoms still persist and she begins to experience an increase in blood pressure, bring her to a sitting position to counteract the hypertension with orthostatic hypotension. Continue to monitor her blood pressure every 3 minutes because it can change rapidly. If symptoms persist, especially increasing blood pressure, a throbbing headache, or nasal obstruction, emergency procedures should begin. Once the AD symptoms have abated and the cause is related to performing the pelvic exam, consider rescheduling and pre-medicating with nifedipine or nitrile paste. In addition to autonomic dysreflexia, there is another issue to be aware of when performing the pelvic exam.
Okay, having a spasm?
Yes.
In women with spinal cord injury, spasticity can affect the exam, especially if it's in an arm, leg, or abdominal region. It may range from slight tremors to quick, violent contractions. They can be caused by any new or uncomfortable position. It's best to gently support the spasming area and wait until it resolves to continue. Never leave a patient alone who is spasming. It could cause a woman to fall or injure herself. Palpating the ovaries is difficult if the abdomen is rigid due to spasticity. To obtain an accurate exam in women with spasticity, you should instruct your patients to pre-medicate with antispasmodic medication 1 hour before the exam. Now that we've reviewed some advice for facilitating the pelvic exam in women with spinal cord injury, we'll move on to the importance of breast health in these women and all women. Breast cancer is the most common cancer among women. According to the National Cancer Institute, every year over 185,000 women are diagnosed with it, and nearly 45,000 will eventually die. About 1 in 9 American women will develop it during their lifetime. If breast cancer is detected early, when it is treatable, the survival rate is nearly 90%. Clearly, breast cancer is a concern for all women, and spinal cord injury does not make a woman immune. The best way to promote breast health in women with spinal cord injury is to encourage regular clinical examinations with a physician, mammography appropriate for the woman's age, and monthly breast self-exam. Specially designed equipment is available for performing mammograms on women who use wheelchairs. These systems have a tilt arm that conforms to a woman's seated position. If these units are not available in your area, seek out experienced technologists who can facilitate an exam on a woman who uses a wheelchair. Above all, stress the importance of age-appropriate exams to all of your female patients with spinal cord injury. Since most breast changes are discovered by women themselves, and it is usually women who can detect them at their earliest stages, it's important that all women get to know the unique shape and makeup of their own breasts. This is done through monthly breast self-exam, and it is another important practice in ensuring the early detection of breast cancer. Advise women about the best time to perform breast self-exam, usually 1 week after each menstrual cycle. For those no longer menstruating, it's best to pick the same time each month. If appropriate, some women can couple breast self-exam with the same day of the month they do their indwelling catheter change. Women with spinal cord injury need education on how to do the exam properly and how to accommodate any impaired sensation or movement that may influence the exam. Educational videotapes and booklets are available to help.
Have your attendant do the very same thing on the other side, since you can only do that one side.
A woman with tetraplegia may be able to perform the visual part of the exam, but may need the assistance of a spouse, family member, or personal care assistant to perform the palpation exam. Again, this may be an issue of concern for your patients with spinal cord injury. You should encourage the importance of regular breast self-exam and direct women to use others to assist with this important health maintenance procedure. Education and encouragement are the keys to helping women with spinal cord injury seek out regular gynecologic care and for it to be a positive experience. There is much you can do as a healthcare professional. One of the most important is listening to the coping strategies women have learned over the years. One particular area where this can be appropriate is menstrual management. Experienced women have much to share with those with new injuries. You can facilitate this by passing on the information.
I have mood changes. I do have some swelling, additional swelling in my feet around the time of my cycle. I can tell some changes in my breast, tenderness in my breast. And so I have a little bit of notice, plus I keep an accurate calendar.
Just before my period, I usually have more bladder spasms, and sometimes I have more swelling in my ankles.
Before my disability, I would have cramping a couple of days before, and that would give me a sign that my menstruation was about to come. But now I have no signs, so I usually keep it with it on the calendar. I have no swelling, no cramping or anything.
I use tampons. I prefer tampons. It's just a problem. A lot of times, like say I'm at work and I do better pulling pants up. If I've got pants on, I do better if I'm able to recline and get them up. So a lot of times I have to ask a coworker to come in and help me get that last little tug on my pants.
I can't use tampons because I wear an indwelling catheter, and that, I guess when the tampon expands, it presses on the catheter, and then I have problems with the catheter leaking. So, I stick with pads, but using a tampon at nighttime will work because I'm not up moving around. There's not as much pressure on the catheter, so that will work for me.
I said, I never really even considered a tampon since I've been in this chair. I guess I never even thought that I could. So I'm sitting here listening to both of you. I never even thought that I could ever use one.
You're at work or wherever and you have to change your pad and you have to push it down in your clothing. You know, your catheter might get pushed down, the tubing might get pushed down. It's possible you could kink it off. I've always been so super conscious of that and making sure that my catheter is always in the right place so that that doesn't happen, because if it gets kinked off, then you've got a whole lot more problems than, you know, a little leakage from your period.
You may want to know a few other points about menstruation in women with spinal cord injury. Remember to warn your patients about the risk of toxic shock if they are unable to change their tampons frequently enough. Also, for many, urinary tract infection can be a sign that a period is about to begin. Being prepared for what to expect and how to manage the menstrual cycle post-injury is something healthcare professionals must be prepared to discuss. It's usually up to the professional to initiate the subject and help women devise coping strategies. I hope this program has given you insight on helping women with spinal cord injury recognize the importance of proactivity toward their gynecologic health. We discussed the importance of regular pelvic exams, including pap smears, bimanual exams, and hemoccult tests. We showed how special transfer and positioning guidelines can help you perform an accurate exam and help women have a positive experience. We explained how many special concerns that may affect the exam and how knowing about these in advance can help you and your staff prepare and accommodate accordingly. We encourage you to stress the importance of doing monthly breast self-exam and scheduling regular mammograms with your patients. And finally, you heard the experiences of women and how they are dealing with menstrual management issues. Hopefully, these will help you counsel women with new injuries. Your interest in this subject can make all the difference for women with spinal cord injury. Female reproductive health issues after spinal cord injury are vitally important to your patients because in all respects, they are still women.
Someone mentioned that because I've had a spinal cord injury, nothing else bad will happen to me. But I think we've known a couple of women who have actually died from ovarian cancer or breast cancer, who were paraplegics, quadriplegics, and they, I guess they just weren't really being followed closely by a doctor because they felt like they were kind of in the safety zone.
That's why I will encourage women with disabilities, get your checkups.
When you maintain yourself, take good care of yourself, have regular checkups, you feel happier about your life and you feel good about yourself, which to me helps me get through days when maybe I'm not feeling so positive about my disability.
Your body's got enough to deal with, so try to take good care of it. Have regular checkups, do what you can, like regular breast exams at home, and find a doctor that you're comfortable with.